modern societies prize autonomy. We believe adults should be free to live as they choose, even if those choices are destructive. But what happens when mental illness erodes a person's ability to choose at all? A visible minority of people living on the streets are not simply down on their luck. Many struggle with severe schizophrenia, bipolar disorder, traumatic brain injuries, or substance-induced psychosis. In these cases, freedom can become a trap. Untreated psychosis impairs insight, anosognosia, meaning a person genuinely does not believe they are ill. Expecting voluntary treatment from someone whose illness blocks awareness is often unrealistic. The result is a revolving door: emergency rooms, short jail stays, brief shelter placements, then back to the sidewalk. This cycle is not compassionate. It is chaotic, expensive, and destabilizing, both for the individual and for already overburdened social service systems. Structured involuntary commitment, when narrowly applied and legally safeguarded, can interrupt that spiral. Historically, large institutions were often abusive and underregulated, and those failures should not be minimized. But modern models of secure psychiatric stabilization units, combined with court oversight and clear discharge planning, are different from the asylums of the past. Evidence from assisted outpatient treatment (AOT) programs shows reductions in hospitalization, incarceration, and violent incidents when individuals with severe mental illness receive mandated treatment alongside housing and case management. The key is not punishment. It is continuity of care. There is also a moral argument. If someone is so impaired that they cannot feed themselves, maintain hygiene, or avoid repeated victimization, strict non-intervention may not be respect for liberty. It may be abandonment. In medicine, we already override autonomy in limited circumstances. Unconscious trauma patients receive care without consent. Severe psychiatric impairment raises a similar ethical question. Social cohesion depends on functioning institutions. When a small but highly visible population cycles endlessly through crisis systems, public trust erodes. Thoughtfully designed commitment policies can reduce suffering, stabilize neighborhoods, and relieve pressure on emergency services. The real debate is not freedom versus force. It is how to design humane guardrails for people whose illnesses temporarily remove their ability to choose stability. Compassion sometimes requires structure.